Perfect. So we leave this as it is. So when the session starts, yours is the first talk. So we'll move ahead with that. Okay.
So we start at 12:30, I suppose?
Yes, the session starts at 12:30. Yes.
Yeah.
Good morning. Good afternoon.
Good
Yes.
afternoon, Dr. Shikha. Can you hear us?
Yes, ma'am.
Okay. Would you like to come on video, ma'am? Perfect. Great. So Dr. Ashwini is already online. We'll start the session, say another 4 minutes. Is that okay?
Sure.
Great. Thanks.
Hi, Shikha, where are you?
Good afternoon, sir.
Good afternoon. Where are you sitting?
Sir, I'm sitting at Shivalik. Where are you?
Actually, you're in Delhi.
Hanji.
Actually, I thought it appeared you're sitting in a car or something. You're traveling somewhere. No, I'm at work.
Okay, okay.
I can see me,
Good
I
to have
suppose.
you here, sir. Yes. Right.
My familiar seminar room, okay? Same place.
Hanji.
From the seminar room only, or Loknaik only. Am I audible?
Okay, that's wonderful. Yes, sir.
So we start in about 2-3 minutes more.
Yes. So, ICGB team will prompt us to start, or what is the
Yeah.
plan like?
Yes, we'll prompt you in another 2-3 minutes.
All right.
All right, thanks.
Thank you.
सर नमस्कार जी हेलो सर नमस्कार
Good afternoon.
नमस्कार, हाय, हाउ आर यू? मैं बढ़िया, आप सुनाइए. हाँ बोले, क्या थोड़ी आवाज कटी आपकी. यस, लॉन्ग टाइम रियली. आप आए नहीं बहुत दिन से.
आए थे, अब मिल नहीं पाए उस दिन. कोई बात दोबारा.
आई नो, उस दिन मैं नहीं था उस दिन. हाँ आप आए थे. या
आज जरूरी आना है आपको.
हाँ, मिलते हैं, शाम को मिलते हैं.
पक्का.
पक्का सर.
Sir, we'll start in 2 minutes. We'll just wait for people to join.
All right.
Recording in progress.
morning, good afternoon, depending upon your location. So welcome to this last day of workshop, and today we have very eminent speakers on clinical biology of tuberculosis as well as cellular biology, development of drugs, mostly on tuberculosis. And to chair the session in the morning, we have with us Dr. Shikha Dhawan. Dr. Shikha did her PhD from University of Delhi, and then she did postdoc from Biomedical Research Center in Boston. She is instrumental in establishing and implementation of National Health Program and National Tuberculosis Elimination Program in India. She now works with Share India Foundation. Shikha, over to you.
Thank you, Dr. Asif, Dr. Pawan, and entire team of ICGB for having us here. It's an honor and privilege to chair this session. To begin with, I would like to introduce everyone to the speaker, Dr. Ashwini Khanna. Dr. Ashwini Khanna is a physician working at Lok Nayak Jayaprakash Narayan Hospital, New Delhi, India. Dr. Khanna is a TB specialist and can rightly be called one of the finest doctors in the city. He has served as State TB Control Officer for Delhi under the National Tuberculosis Elimination Program, Ministry of Health and Family Welfare, Government of India, and he has been instrumental to provide technical and managerial leadership to anti-tuberculosis activities in Delhi and is strongly working towards the goal of ending TB. His key strengths are to implement, prevent, detect, and treat tuberculosis, and building pillars for universal coverage and social protection for tuberculosis in Delhi. Also, Dr. Khanna is spearheading many health research studies, operational and implementation research in tuberculosis. Today, he is going to enlighten us with regards to the evolving trends in treatment of drug-resistant TB. With that, I invite Dr. Khanna for his talk on changing trends in treatment of drug-resistant TB. Thank you, and over to you, sir.
Thank you, Dr. Shikha, for that introduction. And I'm certainly privileged to be here speaking and having invitation from the ICP to be part of the program. So like you said, I'll talk about the trends, how the trends evolved over time in the treatment of drug-resistant TB. So I'll start sharing my slides now.
And so there's just a housekeeping announcement. We request all the virtual participants to send their questions in the chat session, and as per time availability, those questions will be taken up. Thank you.
So, okay, so now, like I said, the topic is changing trends in the treatment of drug-resistant TB. And this is very important part of the program because these are the patients who have a poor outcome. So I think most of you are aware that the treatment of TB is available since 1940s. Prior to that, there was no treatment. People had to be treated in sanatorias where sunlight and maybe good food, nutrition was the hallmark of the therapy. And most of the patients were lost, they died, but there was few survivals and they were minimal, but 10 to 15% had a natural innate immunity where they could survive. And even after the discovery of the drugs in 1940s, it is well known that organism develops resistance to the drugs unless they're given in a specific combination and for a specific duration of time. The first drug we discovered was Streptomycin. It was in 1943 by Dr. Waxman. And after that discovery, we've had a whole armamentarium of drugs, and they were available in 1960s and 70s. So a lot of drugs were discovered in this meanwhile. But then there was a gap. After the 60s, 70s, it took nearly 40 years for the new drug to be discovered, and that was a drug called bedaquiline. So this new pipeline was rejuvenated with the discovery, and now we have a delaminate, which was available in 2014. And now there are researches with more drugs in pipeline. We have a big pipeline where more drugs are coming in, they've been tried out. And some of the existing drugs which were already there have been repurposed for drug-resistant TB. But still, there is always a danger of development of drug resistance, and then it affects the management of with the TB. Now, TB is certainly a disease which is, is on where the whole world is looking at elimination, And for last 200 years, it's been called captain of all these men of death. When we see all the deaths, all the diseases like smallpox, malaria, plague, cholera, AIDS, all combined, the number of people who died of TB in last 200 years was more. You can see that in the chart. Amongst the organism, TB is the single most common cause of death amongst infectious agents. Even though it's the 10th cause of death, as far as the number is concerned, we lose nearly 1.5 million people every day to the disease, every year to the disease, with ischemic heart disease on top. But as far as the effective agent is concerned, tuberculosis is number one. And when we look at the burden of the disease, both the TB and the drug resistance, I'll be talking more of drug resistance. We have a global report 2021, which tells us we have nearly 9.9 million cases every year, and India with 2.6 million has 26% of the global burden of normal TB. We are losing about 1.5 million people every year, and India has a loss of about 34.5% of them are from India. But multi-drug resistant TB, we have 500,000 cases worldwide, nearly 465,000. That is about 500,000. And India, with again nearly 250,000 of these cases, have about 27% of the burden of this disease. When you have a rate, when you look at per 100,000, normal TB is about 188 per 100,000 population. But still, multi-drug resistance, even though the number is less, the outcomes are very poor. And we need to ensure that we don't have an epidemic of this disease in the country. Certain parts of the world do have a very high prevalence of drug resistance when you compare with what we have in India. In India, it's very less. It's not a major concern, but worldwide, in certain parts of the world, the number is very high. Now, what is drug resistance and what is the problem with it? Now, TB that is resistant to drugs is certainly more difficult to treat. And the two most important drugs to treat this disease are rifampicin and INH. And they're very powerful drugs. So any patient who's resistant to these two drugs is called a multi-drug resistant TB infection. So that means this organism, which is resistant to two of these most powerful drugs, are called MDR agents, MDR, and cause MDR TB. Now, there is another term called XDR, that is extensive drug resistance. That is persons who have to be treated with drugs other than rifampicin and INH. They have, plus this resistance, a resistance to fluoroquinolones and second-line injectables, which are important drugs to manage MDR TB. So if you develop resistance to this, there is extensive drug resistance. And this resistance can be result either from transmission from one person to another or a failure of the previous treatment. So one has to ensure that the patients are segregated or taken care of early so they are able to decrease this transmission from one person to another. And this antimicrobial resistance is increasing, and there is always a danger of likelihood of this epidemic with difficult to treat strains. Now, what are the issues where we have a drug resistance TB? The problem with resistance is normal TB takes 6 months to get cured, and it has a very high success rate. We are able to cure nearly 95% of the patients with a drug-sensitive organism. But there is a problem is of a longer duration for drug-resistant TB, especially the MDR TB and XDR TB, which we'll talk about. And then we have to deal with toxic drugs. All the second-line drugs are very toxic. They're comparatively less potent. And because of long duration of treatment, there's a high default and end up, we're having a very poor success rate because a lot of patients are lost because of long duration as well as toxicity of the drugs. So over a period of last, roughly about 15 years, since starting in 2001, we've had drug resistance surveys we've done doing periodically to see what is the burden of estimation of drug resistance, especially the MDR. And we find that the first survey, which was done in 2001, we had amongst the patients who had not taken treatment earlier, had about 1.7% were resistant to both the drugs, rifampicin and INH. And over the period of time, the last drug survey, which was done at national level, we have this figure reaching up to 3.5, that is about 2.84% are resistant to both these organisms, both these drugs. And there are other studies, which are some national studies, which were done in Hooghly, Gujarat, Andhra, and Tamil Nadu. And we have seen amongst the drugs, people who have taken drugs earlier, treatment earlier, we have a figure of roughly up to 5%, roughly 3% of people were resistant at the inception of treatment, which has gone up to roughly 12% as per the latest drug resistance survey. which you can see here. So as per the National Drug Resistance Survey, which we have here, which is the latest survey which was done, we find that MDR is roughly to tune of 2.84% amongst the patients who not taken treatment earlier, and it's nearly about 12% amongst the people who have been treated earlier. Now, what are the regimens when we start talking? Now, I'll concentrate more on the regimens. I want to show how the regimens have changed and how we are moving towards having a better results based on whatever studies we have and whatever the drugs are being developed. We started our national program in 2006, where what we have called DOTS Plus, that is, for treatment of drug-resistant TB, and the guidelines were, started there. And we were treating the patients for 24 to 27 months. Those are MDR patients. So MDR patients are one which are rifampicin and resistant to INA. The treatment was long. It was nearly 27 months. And for 6 to 9 months, we had to give injectable. Again, a problem with the drug is a toxic drug. It leads to ear problem. And this drug was given for 4 to 6 to 9 months in a patient, depending on how they respond to the therapy. And it was 6 drugs were given earlier. And after 6 months to 9 months, 18 months of therapy was given with 4 drugs. The duration remained long, 27 months. And in 2009, we started treatment XDR. Those are people who have rifampicin plus patients who were, resistant to rifampicin, to quinolones, and that is, we can see ofloxacin, what we did earlier, and injectables also. So this was a group of XDR who were to given treatment, which was again a long duration or a longer duration stay, and the treatment was up to 30 months. Again, there was 12 months of injectables, nearly given 6 days in a week for a period of 12 months with that associated toxicities, and number of drugs were high. 2012, we standardized the regimen, we changed a bit, and 2014, we had availability of drug sensitivity to these second-line agents like injections and quinolones injections, which were aminoglycosides and levoflox. Since we had second-line drugs sensitivity pattern available for us, we changed the regimen accordingly. But still, the duration of these regimens were as long as earlier. Only thing, they were slightly now we were doing drug sensitivity-based testing treatment. This is to show what was the comparison of the success rate in MDR TB, that is rifampicin INH resistance, and XDR TB, that is MDR plus resistant to more important drugs which were used in MDR. And we are comparing India and the world. In the MDR patients, the success rate always stayed around roughly 50%. Starting from 2007 to 2016, there's hardly been change. And the similar success rate was seen in India, where we had a figure touching nearly 50% at the most. And XDR was abysmal. We had a very bad success rate, and the success rate was 31% in 2016. And it hovered around that figure, roughly about 25 to 30%. Only 1/3 of the patients who were started on treatment for XDR had a successful outcome. We lost a lot of them. The breakup, what we see was success was 50%. And why we had a poor success was there was loss to follow. A lot of patients, because of long duration of therapy, were leaving the therapy. And of course, the toxicity of drugs made them lose. A lot of patients, 15 to 20% were lost because of the extensive disease they already had. They died because of the disease. And then the few patients failed on treatment. There has been a change now. We have newer drugs available. We started in 2016, and the most important drugs were bedaquiline and delamanid. Bedaquiline is a direct quinolone that was specifically targets mycobacterial ATP synthase and was available to us in 2016 when we started using this drug. This drug has a very strong bactericidal and sterilizing activity, and it has extended half-life. And what we found that when used in these patients, it significantly improves time to conversion in MDR patients who were put on treatment. And delamanid, another drug which was available, another new class of drug, and it was used, and it acts by blocking the synthesis of mycolic acids, and it also poisons the bacilli with nitric acid release. So both these drugs have been made available. So we have tried these drugs. And the first time we tried the drugs was in 2016. We had a conditional access program in India, and this new drug was approved in 2012 by FDA, but we tried in India under a cap. That was conditional access under the national program. The idea was to leverage its potential to improve the treatment outcomes. We saw the treatment outcomes in XDR was hardly 1/3, 30%. So to improve the treatment outcomes, and we introduced a protocol for its introduction through a multi-centric study, which was developed in the country. The new drug was introduced initially under the program that was conditional exit. It was only available in the national program at 6 sites with the objective to generate evidence on its efficacy and safety profile amongst Indian patients. And Delaminate was another trial drug which was started in 2017. Now, when we talk about the success rate of MDR on different regimen, I think you've already been told very clear over the time, the success rate in MDR is about 45 to 50%, a poor success rate. Only half the patients were able to get cured. But XDR, again, repeating the same thing, we had a success rate of about 1/3 of patients successfully completing, having a successful outcome. Otherwise, we had lost a lot of patients and a lot of patients defaulted. But conditional access program, which was done in patients who were XDR, that's the last slide, last row we have, where we have a 34% success. The use of betaquilin to the older regimen, we were using the same regimen, we just added on betaquilin to this regimen, we got a success rate of nearly double, which crossed nearly 71%. So this use of this drug certainly brought about a change in our treatment and the outcomes in a patients who had a very poor outcome till now. Now, this is for duration of therapy. Then duration still remains, something like treatment is about 2 years. But shorter NTR regimens was something what we were looking at. And we found that when we started treating drug-sensitive TB, we were using the same different drugs which were available at that time for 12 to 18 months. And we shortened it to 6 months over last two, for 2 decades, 2 to 3 decades. And we are able to get results, excellent results, over 95% success rate amongst drug-sensitive TB with 6 months therapy. So why not use the same look at basically the bacilli remain the same, whether we can shorten the duration of therapy even in MDR TB, which was 24 to 36 months, and also with toxic drugs. Now, this long duration and constitution of the regimens what we're using for earlier for treatment of drug resistance is based on expert opinion. High attrition rate was seen because of long duration. 24 months is long. A lot of people leave the therapy, and outcomes, as you saw in MDRs, was less than 50%. We tried a lot of supports, giving social support, counseling, but hardly had much effect on the outcome, which remained very poor. So the first attempt to have a regimen shortened for MDR TB, that is only rifampicin INH, was done in Bangladesh, and it was done in sites which were run by Damien Foundation. They had some population where they're treating these patients, so they tried the same drugs which were available in the program in novel combinations, and this was done late 1990s. And carried on for 10 years. They checked various regimens and various combinations of the drugs, and they tried to use the drugs which were toxic for a shorter duration or not at all. And the duration was over the time curtailed depending on the different regimen. Over the time they did different regimens, saw how the first regimen behaved. They found there was poor result. They changed the regimen. They kept changing the regimens, and then they finally came to a regimen 6. That is after 13 years of trials in the different regimens with success, and they found that the last regimen, which we'll talk about, which we call a Bangladesh regimen, had an overall success rate nearly touching 88%. And very good, poor, relapse rate was very good. Hardly, less than 1% relapsed on treatment when they followed them for 2 years. So this result of 9 months to 11 months of therapy with this new novel regimen which they devised, what they call a Bangladesh regimen, with a very good outcome as well as low relapses. Because when you're giving a duration for less time compared to 24 months, what we are worried about is the patient might relapse. But here they got very low relapses. So this 9-month regimen, which is the regimen 6, what we are going to call a Bangladesh regimen, had 4 months of 7 drugs where they used kanamycin, which was injectable, and quinolones along with this combination of drugs. And after 4 months, this toxic drugs, those are injected, the INH, which was a high dose, and prothionamide, which they used, which was again a toxic drug, and they continued for 9 months, a total of 9 months. So 88% relapse-free cure rate, which was as good as treatment of drug-sensitive TB. This was the first time it was documented. They carried on using the same regimen because here the number of patients which they tried out was something like 206. And finally, they published this paper on 515 patients by Van Buren. It was done in 2014, published in International Journal of Lung Disease and Tuberculosis and Lung Disease. So here, finally, we came to a figure of something like 85% successful outcome with a very low relapse. Again, 2 years follow-up, less than 1% patient relapse. So the results were very good. Like I said, as good as with drug-sensitive TB, but death remains slightly on the higher side, lost to follow-up, because these patients are the ones who were already tried these drugs, put in drugs early, and some because of alcoholism and other reasons they defaulted. But still, a very successful outcome of 85%. So this was the regimen which was used for 5 months. For 4 months, we had 6 drugs, only injectables given for 4 to 6 months, and for next 5 months, only 4 drugs. So based on this regimen, this was approved by WHO, and we have used the same regimen in India now. But besides that, this was the only Bangladesh. These same regimens tried out in a lot of francophone countries, and similar results were obtained. And then, since these were studies, the trials were done. We had something called a Stream 1 trial, where it shows that this regimen was quite efficacious, as good as the longer regimen, which was 24 months in the field trial settings. Now this longer regimen, what we showed, I told you, which was 24 months, what was treatment for MDR and both XDR. Basically for XDR, MDR we had shortened down to 9 to 11 months. For XDR, people who were more than MDRs, the treatment of XDR was still for 24 months. And again, this 24 months had, because of this long duration, a lot of patients will default from there, and deaths were there. These anti-TB drugs now were reclassified because we had some research with the publications in Lancet where all these anti-TB drugs were reclassified, which was based on the individual efficacy and toxicity. About 12,000 individual patient-wise data was evaluated, and based on their efficacy of these drugs, they were reclassified. Injectables, which were aminoglycosides, which are toxic drugs, were moved out of the regimen and were only used as a replacement agent. They were not used as the primary drugs. Only if the primary drugs couldn't be given, this injectable was added. So an injection-free regimen was proposed by WHO, and the duration was further shortened down to 18 to 20 months. So we are coming down from 24 months to 30 months with injectable regimen, and now based on this efficacy of drugs, a new regimen was proposed, and this duration was 18 to 20 months. So the grouping was done, the group A, group B, and group C, and the group A and B were put number 1 to as per the efficacy of the drugs and the toxicity of drugs. And the regimen was to have 5 drugs and 4 to 5 drugs, where we used all the first group A drugs and 1 or 2 group B drugs. And if some drugs couldn't be used in the group A or B because of toxicity or resistance, then we moved to the group C drugs. So injectables came lower down, and it was an oral regimen. So this regimen is about 18 to 20 months, where it is all oral in constitution, and duration has been shortened down to 18 to 20 months. Now the regimen, what we talked about, the longer regimen, which a shorter regimen earlier has an injectable. I said we had 9 to 11 months of regimen, where the first 6 months was 4 to 6 months was injectable. So we need to replace the regimen with an oral the oral drug, especially injectables have to be moved, and oral drug has to be put to improve to see whether it's efficacy. So this was done in South Africa, where a bedaquiline was used in place of kanamycin. Now we are moving to an all oral regimen and a shorter duration, that is 9 to 11 months for drug-resistant TB, which is just MDR and not more. And what we got was by replacing kanamycin with bedaquiline is what I'm going to show you what was encouraging. So this trial was done in South Africa, and what they got was that what they found was when they used bedaquiline, which is an oral drug, in place of a standardized regimen what is using with kanamycin, which is injectable, they found that BDQ containing all oral shorter regimen had a 73% success rate compared to 60% success rate, which was with injectables. We were getting the results of shorter regimen as in India also about 60%, so this was similar figure. The results of shorter regimen of 60% was still better than MDR with 50% in the longer regimen, but the poor result was because this is one regimen, we cannot change the regimen. All 7 drugs have to be given. If, however, any of these drugs have to be taken out of the regimen, then the patient has to be moved to a longer regimen. It's either all or none. So patients, about 10 to 12% of the patients have problem with injectables, that is kanamycin, so they have to be moved out of the regimen. That's why the success rate of this shorter regimen was poor because of use of kanamycin, because it has to be moved out for the regimen. So when they replace with kanamycin with bedaquiline, we have a much better success rate of 73%. So favorable outcomes were significantly better for bedaquiline versus shorter injectable, and this was seen in all the subgroups, including the HIV positive patients. So this is based on this. It was reviewed by WHO, and this is a regimen which is totally oral, 9 to 11 months, which is now the standard of care in parts of India. However, composition or duration of the initial or the continuation phase, this whole regimen cannot be changed. If we need to move any of the drugs out because of toxicity or resistance, this regimen cannot be given. So we have to move to a longer regimen. So what are we moving towards as far as PMDT, Programmatic Management of Drugs Resistant TB in India, 2020? We are looking at moving towards an injection-free regimen. Injections have the problem. One has to go and get regular shots from a doctor, from either nursing place or a doctor. But with the shorter oral regimen, we can take care of this. And we want a shorter duration of regimen to decrease the defaults. We must have a drug sensitivity guided treatment approach. And of course, as far as possible, as simple a regimen we must have. So in 2021, based on the WHO recommendations and endorsement by the National Expert Committee of India, the national program is to shorter oral bedaquiline containing regimen for MDR TB. XDR we cannot use. For MDR TB, and we have replaced injectable with bedaquiline in this regimen. So this has been started out and is being phased up in the country, and we have about 7 states in India doing this regimen today. Now, treatment of XDR still remains long. It's 18 to 20 months, and even though it's an oral regimen, duration is long, and this long duration leads to a very high default rates because people don't continue for such a long time. So a study was done. Now we have something called a BPAL regimen, which is being tried out in the world to shorten the duration of therapy of even XDR. The BPAL is where we use bedaquiline and new drug called predominant and linozolid. Each drug has a potential preclinical and clinical anti-TB activity, and they have hardly been used under the national program in the world because they're all new drugs. There's a minimal, because of which there's a minimal pre-existing resistance. And all these 3 drugs contribute to bactericidal and curative activity. So in minimal animal model, efficacy is better than the first-line drugs, that the drugs which are used for treating drug-susceptible patients. So this regimen was used, the duration was 6 to 9 months. So this has been used in South Africa when we did the next study. So what they found was, with this 6 to 9 months of therapy, with these 3 novel drugs which have not been used earlier, and this was done in patients who are XDR or MDR who were not responding to therapy, or MDR who could not tolerate the drugs which were available treating MDR, so they have to be moved out of that regimen. What they found was that 90% of patients with highly resistant TB achieved a relapse cure rate at 6 months after end of therapy. So we got a success rate touching 90%, which was not even seen even with MDR patients. Even drug sensitivity patients don't have this results, even though it was done in a study mode. And the same results were seen with HIV co-infections. And there was a rapid culture negativity amongst these highly resistant patients. Median time was 6 months. And the data which was analyzed at 24 months, we found that even the long cure rates were high. There were very few relapses. And because when you are shortening the duration of therapy, what we worry about is, are we increase the relapse? And we got a very low relapses. However, the problem of the regimen was linezolid. Linezolid was given in a very high dose, which was 1200 milligram, and it led to a large number of patients, nearly 81% having what is called peripheral neuropathy, and which is at time can be incapacitating condition. And myelosuppression, that is hemoglobin goes down, was nearly half of the patients. So there was toxicity of drugs, and because of this toxicity, either the drugs had to be decreased in doses, and or it has to be stopped. But amongst the patients started on treatment, they were able to change the regimen, but it has to be very carefully monitored to take care of these patients to get a results which were nearly 90%. So just to overcome this resistance, and the WHO approved this regimen under condition, under OR mode for the different countries because of the side effects, and it had only been studied in South Africa till then. Now, what do we look at? Besides shortening the regimen and simplifying the therapy, we must have decreased toxicity. Here we have a toxicity which was touching nearly 80%, even though mild to moderate was there, but it was high. So we must have a decreased toxicity, because if we have to use the drugs in this manner, they should be able to be given periphery, because a large number of patients need to be monitored, need to be monitored if the disease is toxic. But if the same drug is not toxic, it can be given in the periphery with minimal monitoring. So we have another trial called a Xenix trial, where these drugs were studied in multiple sites across Georgia, Moldova, Russia, and South Africa. And this here, what they did was they decreased the dose of linezolid, which was a toxic agent. And what they have concluded, this was in 2021 July, that the new trial with the same combination, that is bedaquiline, preterminate, and linezolid. And the linezolid, the doses were much lower, half the dose or even lower. What they found was the new trial results show effectiveness of BPAL regimen for highly drug-resistant TB can be maintained with drug dosing of linezolid. So this was certainly very encouraging. So, and simultaneously with the maintenance of efficacy, there's a decrease in linezolid side effects. From 80%, we had a side effects nearly touching about 20 to 25% only, and they were minor. So the results of trial has been published by TB Alliance, which is a non-profit TB drug developer. And in India, before we were skeptical using the high doses. 1200 milligram was toxic. We were already having problem with 600 milligram, but 1200 was difficult. So what we are doing is we are going to have a study which we have started in 2 sites already. In 8 sites, we are doing a modified BPAL, where we have decreased the doses of drugs. So these are the 8 sites in India, spread all over India: Mumbai, Delhi, and Ahmedabad, Surat, and Agra, and Lucknow. So these are the sites where we're going to do the study, and we'll come up with a regimen which is best suitable for India and look at the efficacy of this regimen. So we need new defined regimen for highly resistant TB with little or to no resistance. And what we look in the new regimen is shorter duration. XDR treatment still remains long. It is still, as per the standard of care, is up to 20 months. With BPAL regimen, we are looking at a figure of about 6 to 9 months, which should allow for quick conversion to interrupt transmission, should be simply to administer, no injectables, improve tolerability and adverse effects, because with the high doses of certain drugs, there is a problem. And of course, finally improve the cure rate. And these are relapse-free cure rates, not only cure rate. There should be minimal relapses. At the moment, we have a present standard of care is we have 2 regimens. For MDR patients, we use shorter oral bedaquiline-containing regimen, which is 9 to 11 months duration, and we don't use injectable here. This is used in about 7 states in the country, and scale-up program is on. The longer duration is used for people who cannot be given shorter regimen because of maybe toxicity of the drugs, or they cannot tolerate some drugs, or in the XDR patients. So this longer regimen, which is 18 to 20 months of regimen, again, it's an oral regimen. So both the regimens, as far as the treatment of drugs and TB, both MDR and XDR are moving towards all oral regimens with shortening of the dosage, shortening of the duration. This is how we evolved over time, started in 2006, and now what we have in 2019, we have an all oral regimens. Now, evolution of drug for the shorter regimen over next 3 to 4 years, we have a pipeline of different studies which are going on, which are on. Some are results are there, some are expected next 2023. So we are moving towards regimen which are 6 to 9 months in duration or maybe shorter. What are we looking at? What we realize Equilin will remain a backbone for all these regimens. We are 2022, we are still having up to 7 drugs. You can see even the duration is shortened. As per the national program, the number of these drugs remain high, up to 7. We are looking at in 23 to 25 moving towards, drugs like regimens like BPAL, which is just 3 drugs or maximum 4 drugs, depending on the different studies concerned, and end maximum of 3 drugs, simpler, given a fixed drugs combination at the most for 3 to 4 months, and all tolerable. We have a bedaquiline in place, we have Streptomycin, and we are looking for some new drug which can give us this support for further duration, for decreasing the duration of therapy, even for MDR, XDR patients. So status of DRTB service in India has to be complemented with what we are doing now, and we have a large number of facilities where we have a genes expert which are spread all over the country, NATs, molecular testing, and live probe assays, which are spread all over the country to manage all these patients. Gradually, over the period of last 1.5 decades, we have increased the number of drug detections and number put on therapy. So I thank you all for this patient listening, and end my talk here now. Thank you.
Thank you, sir. That was an excellent session, and thank you for taking us over the evolving landscape for treatment of drug-resistant TB. So there's a very interesting question for you in the chat from Amit Singhal. So his question is very interesting. He wants to know, instead of talking about antibiotics for tuberculosis, Mycobacterium tuberculosis, why are we not thinking about including host-directed therapies in MDR and XDR regimens?
See, let me be very clear. I'm a clinician. I'm open to all these suggestions. All this research work has been developed by people like you. End of the day, what we get is a drug, we get different modalities of treatment, we get the various efficacies. Certainly, we are looking at different things. We're looking at the vaccines also. They are in pipeline. You have vaccines to prevent disease. We have vaccines to take care of the infective agent in the patient who's already diseased. So it's an open pipeline. With any new direction, with a good outcome, will certainly be tried in the national program. I think worldwide WHO will certainly approve it if we get better results with any of them. So why not? Why not a host directed? We are all open to it. We can try it.
And just to add on, sir, there are global initiatives which are inviting new initiatives. So FIND has had an initiative called FEND, which was looking for new diagnostic. So the research community should apply, and so that we build a very robust pipeline down the line. Thank you, sir, for answering that. So there's a very interesting question again from you, from Dr. Dinesh Gupta. He wants to know what would be the realistic target for elimination of TB in India. So the $1 million question.
Again, certainly $1 million question. COVID not been there, we might have made a dent. But COVID has ruined everything. We are having a less detection compared to, we have nearly 20% down from what we are looking at. So there may be a delay, but then of course the efforts are from all sides. Earlier, we were just treating patients who were having disease. Now we're looking at the latent TB to prevent that side where the pool of disease will come up from. So there is a wholehearted approach. If you ask me, I'm not going to be able to answer that question. Realistic figure is difficult to say, but of course, we'll have to make an attempt to try to reach a realistic figure. Yes, the goal is certainly very, very difficult. It's very challenging at the moment.
Khanna sir,
thank you, sir. So with that, we conclude your session today. So thank you so much for being here.
Shikha, I have one question.
Yes, sir. Over to you, Dr. Pavan.
We have touched, it's a great talk, very impressive talk. But one question is, from the time the patient starts feeling and up to when we start the treatment, there is a big gap. How are we actually going to fill that gap? Because still, though we have lots of diagnostic tools, but when a patient starts having some symptom, and by the time we start the drug regime, there is always a big gap I am finding whenever I talk to many patients and all those. So are we doing something in this regard?
What we find is that by the time the patient comes to a setup, he's already done a lot of medical shopping. He has bought, and that is a lot in private sector. He has visited a lot of people, he's having symptoms. It is roughly 2 months by the time he comes to us. He has been to about 3 to 4 physicians, maybe local physicians by the time he comes. So this has been done by increasing the awareness of the patients, that as soon as they have a symptom which is suggestive of TB, which is being done, they should come to the setup. But yes, the second part is once he comes to you, there is certainly a little bit of delay further. And this delay should be minimal because we have rapid diagnostics. And if you're in a tertiary care setup, normally it should take about 2 to 3, turnaround should be 2-3 days, because we have a rapid test. Sputum hardly takes a time. Molecular tests are available in 2 hours. We have results. So there should be no reason, we shouldn't condone the delay. But still, turnaround time still is about 3 to 4 days among drug-sensitive TB, and in drug-resistant TB, it is up to 7 to 10 days and even longer. But half of the patients are put on treatment within the 10 days, even in drug resistance, but a large percentage are having a delayed treatment initiation. And mostly it is because of we have a pre-treatment evaluation, acceptance, and non-availability of, some patient might have to be admitted who are sick, but majority of them still take time because of medical shopping initially and drug resistance. What we find in Delhi, I can give you a figure, half of the patients are started treatment within 15 days, yeah. And most of them are started in treatment in 3 weeks, but you have still a certain number who are not started even at 1 month.
Thank you. So I think this also has to be looked into this if we really
Yes.
want to achieve something. Because that.
So this is what when we evaluate a program, this we keep doing. Are we decreasing the turnaround time for a patient from diagnosis to put on treatment?
Thank you, sir. Thank you. Beautiful talk. Very nice.
Dr. Pavan, just wanted to say, though we have overshooted our time, but there's another very interesting question in the chat box. Probably Dr. Khanna could take it up. Dr. Urmi Bajpai wants to know, are there any new things on the pipeline for drug-sensitive TB, especially after the successful rifampicin MOX 4-month regimen, which was done by CDC? So, sir, she wants to know anything on the horizon for drug-sensitive TB as well?
Thank you. It's a nice question. The thing is, we are still having 6 months of therapy for drug-sensitive TB. And we need to decrease it further and with similar results, because as you decrease the duration of therapy, we are more worried about the relapses. So there is a trial. I'm a part of the trial. We're going to start it very soon, which has been approved, where we are doing a moxifloxacin-based regimen. And this is for 4 months. We are starting it in 5 sites in India. And my setup is one of the sites where we're going to enroll about 500 patients. We have already had initial studies which have proved the efficacy of this regimen, where 4 drugs plus moxifloxacin is added. And there's a 2 months of intensive phase with the same drugs as in the drug sensitive plus moxi, and a continuation phase, again the same way we are doing it under the national program, but this is shortened to 2 months with the addition of moxi. So we hope to have a good results, and soon we should become part of the regimen. Yes, and rifampicin, of course, the studies have shown with good results, and again, the national program will be looking into it.
Thank you, sir. Very well said. So, sir, with that, Dr. Asif, how do we close Dr. Ashwini's session? Over to you, Dr. Asif.
So he can just stop sharing and I will remove him from co-host.
Okay, so thank you, sir, for being here today.
Okay, thank you so much.
Thank you.
And,
As we move on, I would like to invite our next speaker for the day. Our next speaker is Dr. Venkatesh Rodavar. Dr. Venkatesh is Project Director, TIFA India at JSI India, which is an Indian component of public health research and consulting firm John Snow USA. Now, a word about TIFA. What is TIFA? TIFA is the Tuberculosis Implementation Framework Agreement, which is a key component of USAID's Global Accelerator to End Tuberculosis, with focus on countries like India with high burden of TB. So Dr. Venkatesh is leading this initiative. Besides that, Dr. Venkatesh is a public health professional with more than 17 years experience of working with government, non-governmental organizations, and research institutions. His expertise includes health program management and disease control programs, especially in the arena of tuberculosis, leprosy, HIV, AIDS, and implementation of universal health coverage. Dr. Venkatesh was awarded with Dr. KSN Murthy Memorial Gold Medal Award for TB advocacy, communication, and social mobilization, and also received UNAIDS Felicitation Award for excellent contribution to the cause of AIDS awareness. With that background, I invite Dr. Venkatesh to talk on public-private mix under India's National TB Elimination Program, opportunities to engage private sector to end TB in India. Thank you, and over to Dr. Venkatesh. If you could share your slides, please.
Yeah, I have shared, Dr. Shika. Can I use?
So over to you.
Yeah, thank you, Dr. Shika and Dr. Asif and team for inviting me. Though we had a couple of exchange of emails, I was always thinking that I'm maybe the odd one out in this larger scientific workshop. Thanks for such a kind introduction, Dr. Shika. I come from largely a project management background. I was associated with many public health programs, largely leprosy as well as TB. And today's talk is more on the private sector engagement. And we heard a couple of things from Dr. Khanna sir's presentation in terms of the private sector, how it is important to early diagnose and initiate the early treatment. Until we don't achieve that, I think it will be difficult to think about ending TB by 2025. So I will touch upon largely in terms of the private sector engagement and how it is important, and why we need to work with larger private sector pool which is available in India if we wanted to really achieve these kind of a huge task of ending TB in India by 2025. I'll just, a couple of slides would be a kind of a repetitive what Khanna sir has really introduced to us, but I think it's more of a thought-provoking, just to consider TB is a kind of a global pandemic in the context of COVID, the way the entire mechanisms have moved towards bending the COVID crisis. So similarly, in terms of TB, we all know India contributes close to a quarter of global TB burden, and it has a huge TB mortality. But at the same time, we are still continuing in the same phase, and how long we will continue with the same kind of a phase, and when we will going to really achieve the target which we have set for ourselves by 2025. So this gives a kind of an overview, the level of burden which country has, and the treatment which particularly in TB, which is very much long, from a 6 months for the sensitive TB to a 24 months, up to 24 months. And we have heard about different therapeutics which clinicians and many of the scientific communities are trying to reduce those treatment duration by almost half of that for the TB drug kind of a regimens. These are all leads towards how quickly we can achieve that goal, how early we can identify or diagnose and treat, early treatment for the patients. So just to give an kind of a background that almost every TB public health programs are going for the past couple of years, but we never had a target, and that goes back to the National Health Policy 2016, which probably highlighted that we should set for, kind of a targets, and TB is one among them that they have set a target of 2025. Otherwise, we will keep on continuing, what we do continuously. If you see very interesting facts, we have treatments, we have, all, rapid diagnostics, but still, we have a huge challenge in terms of achieving that goal. Just for the sake of, setting the context, it is like, the TB bacteria was discovered around 139 years ago. A vaccine was, first created 100 years ago. And, the treatment to treat TB was discovered almost 75 years ago. But the situation remains the same. We have not really achieved, what we wanted to achieve in terms of the elimination from this country. And one of the, key factors why we are still struggling more than medical, I think probably, in terms of access to, services, suboptimal nutrition, it's more of a social determination, and lack of, awareness of the knowledge, and, a massive stigma which is associated with this disease. And one of the most, complex is the non-completion of the treatment, because considering this long duration, how we can, definitely, bring out some sort of a shorter regimen, or, a kind of very efficacy kind of a treatment regimens, which probably help in terms of, completing that treatment. And also suboptimal quality of diagnostics and treatment. And this is largely towards the private sector. If you see in terms of the TB elimination goal, we have set ourselves 2025, and TB elimination program is providing a larger kind of a free diagnostic and as well as treatments which are available in entire the country. And we have expanded the rapid diagnostics across the country. We have seen some figures, but still I think nearly 70% of the people who starts their treatment in the private sector. If we refer back to the NSSO, the survey results, which almost indicates similar sort of statistics, almost 70 to 80% of the persons who basically visit as a first point of contact is the private sector. And if we don't engage them, it will be definitely it will be a big task, a difficult task to really achieve the goal. So in terms of that, we have a lot of notifiable diseases in this country, and the TB is one among them, which Government of India has issued in 2012. But it has not really yielded a kind of a result the way we expected in terms of the notification, every single notification to the public sector. And in that direction, in 2018, there was a very big milestone in terms of the TB gadget, which had two important, prolonged strategies. One is Schedule H1, which is a mandatory, as per the DCGI, to manage or maintain the record of Schedule H1. The second is a mandatory notification. Notifiable disease, probably, they do not have much of legal compliance, but as a gazette, it has become a mandatory for every single provider has to notify a TB patient to the larger public health program, that is NTEP, so that once a patient is under the surveillance, it is a kind of a mandatory for the program to provide the treatment support, ensure that the patient is completing the treatment. Otherwise, that will lead to, once again, a kind of a resistance TB or a recurrent TB. So these are started giving results. If you can see the kind of a graph at your right side, which shows public sector itself, contributing almost 80-90% of the TB notification, considering a huge private sector, almost 70 to 80% of the private sector, but their notification is hardly about 5 to 10%. And these has really, pushed the TB program to think about how to engage the private sector. And just to set the context, the private sector engagement started in TB program in mid 1990s, but it has not yielded the expected level of the results. And government attempted in 2018 to revise that partnership guidance, bringing the core element of equal partnerships rather than one-sided, which is more from the program side. what they say they have to do it. Instead of that, I think they have brought an element of equal partnerships, giving a lot of flexibilities so that each and every private sector provider would be able to notify the TB patient to the program. So after this guidance document, one of the promising result is that in 2019, almost 600,000 cases, 6 lakh cases from private sector was notified to the program. I think that is the highest number in the entire NTEP's program life cycle. And unfortunately, we have come across the COVID-19, which has really impacted in terms of not only in public, but also in the private sector. So still everything, the entire program, as well as, we are trying to, engage not only the individual providers, but even the chemists and the diagnostic centers so that they can, notify each and every single patient, notification to NTP. So why public-private partnerships have been attempted, and but there are like varying degree of successes. Why? Because these are like very rigid. Previous partnership guidelines never had much of scope for the private sector to engage the way they wanted to engage. But this the current guidance document has given that kind of a flexibility. When I say the flexibility, it has flexible to start their own treatment regimen, and the program can sensitize them in terms of the standard regimens, which as per the STCI, Standards of TB Care of in India. But what we are looking is primarily the notification to the program, so that the program can take an action following with these patients to ensure the treatment he will complete. So so considerable amount of money has been set aside for these partnerships, and of course including many of the state governments also have come forward with their own kind of an innovative approaches to engage they within their respective states with almost all kind of private providers. Contracts with the government can take many of the forms. So in the current the guidance document, it has been given a flexibility. Instead of giving a fixed rate, it has been given a kind of opportunity for the state governments to do a market scan and come up with their own price. So we have 3 types of partnerships now. One is input based, which is more of a conventional way. So far, the entire program has gone run on the principle of input based, but now we have introduced 2 more methods or the models of the partnerships. One is output based partnerships, and the third one is fee for services. So fee for services is basically the way the market has some sort of a rate, so we need to make a benchmark and enter into the partnerships. And output based is more of a result based. Any agency which wanted to play a kind of a catalyst role between public and private, they need to show the results, then then only they get the kind of agreed amount of money. And one such example in India, which has become a global example, is Patient Provider Support Agency. This model started in 2012-13 with 3 sites, Mumbai, Patna, as well as Mehsana. We used to call it PPIA, Public-Private Interface Agency, that has been converted into a PPSA in the program. Now it has been scaled up through NTEP. So for organizations working in healthcare, PPSA contracts are not only an opportunity to contribute to the country's well-being, but also a new revenue opportunity. So what I'm talking is, these partnerships are those partnerships which are very much institutionalized. We are not really talking about other opportunities or other partnerships which probably in terms of the new diagnostics or the new therapeutics, but I think those partnerships are also possible to engage with the through a different mechanism with the NTP program to bring out new tools and new technologies which can help the patients. Why performance-based funding? So far, what our experience is that most of these guidelines, the partnership guidelines, were one-sided directed. There was no flexibility for the partnership or the recipient organization to innovate themselves in terms of providing services. And this performance-based funding will give that opportunity for the recipient organization to innovate themselves as per the local context, and also as per the patient needs and requirement. They can devise their own partnerships, they can fix up their own targets or the results, the outputs of those partnerships. Based on that, NTEP will process and release a kind of agreed kind of an amount to those partnerships within this program. And this will also bring a lot of accountability for both the sides, and this will also bring an element of equal partnerships between program as well as the potential recipient. So this is why we brought more emphasis on the performance-based funding, and I think this is the first of its kind in RNTCP/NTEP. Because no other public health program has such kind of a bold partnerships, and this has become a golden standard, and many of the programs are looking forward to adapt such kind of flexibilities within public-private partnerships. So just to give a kind of a quick orientation, NTEP has a strategic plan, NSP we call it, and based on that inspiration, we have set up a kind of a national technical working group to revise the guidance document. Almost every single stakeholder within this domain was engaged, and we had a series of consultative meetings at the national level, at the state level, before formulating these guidelines. And then we came out with this new guidance document and partnerships. The key changes from the previous guidance to the current guidance is, earlier it was only grant in aid, which were already fixed in terms of the cost, in terms of the services. There was not much of flexibility. Now from grant in aid to the output based contract, where we agree with the outputs, but there is a greater scope for the recipient organization to innovate within the processes, the way he wanted to deliver the services to the patient, which also brings a lot of patient-centric elements in terms of designing these services. And of course, this brings a lot of accountability when we say performance-based partnerships, because this is something you deliver and then only you will get what you agreed in terms of those services. So that brings a lot of accountability, both the sides, from program as well as the recipient. And from prescribed, as I said that, now we are not prescribing any cost. It is everything is depending on the market and what the market discovers the rate. And there are certain methodologies which has been designed or discussed in this document. Based on the market price, we can go ahead and have a partnership with those potential organizations, whether it could be a patient services, it could be a diagnostics, it could be a follow-up, or it could be ensuring the treatment outcome. So there are a range of partnerships available in this guidance document. And more importantly, from a government point of view, these are not guidelines, but this is more of a guidance. This gives a flexibility to the states to adapt their own innovative kind of partnerships, not limiting to what central government says, but because the needs of the states are differ from different state to different states. So these are the fundamental guidance to the states, but states have that kind of flexibility to design their own partnerships in their own context. And one of the key features of these, the guidance document is it is need-based, and I know there is a huge exercise has to be done by the state government or by state NTEP program. Identify what are those needs which state requires, which are not available within the program. It also ensures to align with the standards of TB care in India, and more importantly, these guidelines encourage us to have a patient-centric partnerships. And when we talk about the market, the competitiveness is something key. It's a kind of a foundation, right? So that competitiveness brings a lot of innovation, a lot of cost effectiveness, and a lot of output oriented towards the program. So that is another important characteristic of this guidance document. And ultimately, as I said, that this is more of a performance based based partnerships, it means you perform, you get what you deserve to get in terms of the partnership, the resources. So I think we have discussed all these things: quality of care, I think quality of diagnosis, treatment, and public health measures with minimum amount of pocket expenditure. We know that private sector has different practices in different parts of the country. How do we really ensure that all these practitioners are adapting to these standards of TB care, so that we don't have much of other kind of challenges in terms of the drug resistance, or in terms of the incomplete treatment, or in terms of the very less successful outcomes. So that is one of the core elements of all these partnerships, and it is more of a need based. It is not something which is already available in the private in the public sector. We may not really need any partnership for that, but I think we need to identify what are those needs, and it is more of a patient centric, and it is more of a competitive and performance based approach. So just to give one single example of performance-based partnerships, that is called PPSA. So far, the program has signed a kind of, or I can rather say that approved PPSAs in 213 districts out of 700 plus districts in this country, and this has been dated. And the current this current year, it has probably gone into 300 plus districts of these output-based, performance-based partnerships. And these are largely targeting towards private sector providers who are diagnosing the patient, but still a kind of mediator agency, we call it PPSA, who will support them in terms of sensitizing on the STCIs, as well as reporting every single TB patient to the NICSHI surveillance system, and also ensuring every single patient is followed until he completes the treatment and ensure the successful outcome. So this is one example. In the guidance document, we have entire spectrum of services within TB, where a state can, based on the needs, can adapt and get into the partnerships. So this is something, a very new kind of an approach, which has been taken up in such a large scale public health program in India, and that is NTEP. With this, I will stop here. And I know this is not really a scientific kind of a lecture, but I'm sure there are a greater scope, and I'm sure that there are a lot of young, scientific minds. They can also think about beyond these partnerships, beyond these international partnerships or institutional partnerships, can think about new technologies, new diagnostic tools, which can probably help the NTP program to achieve its goal. I'll stop it here, and thanks.
Thank you, Dr. Venkatesh, for an excellent session. And you are not out of context, I would want to say, because there was a question in a previous session, how are we towards eliminating TB in India? So you have brought out the outline why and how the private sector engagement is important to achieve the goal of ending TB in India. So it was very excellent, Dr. Venkatesh. I would request if there are any questions from physical participants or online participants for Dr. Venkatesh. So Dr. Venkatesh, I have a question myself. I just wanted to check with you that the states are still in the process of engagement with public PPSAs. So how do you foresee this happening over a period of time? Like, because this is very important and we are already delayed in our goal of ending TB because of COVID. So how do you foresee individual states engaging with PPSAs, and how do you see the way forward?
Yeah, so so far it's really an encouraging kind of results. Most of the states do have need and requirement of particularly engaging private sector. So I really didn't touch up a couple of core elements when we say the private sector engagement. Most importantly is that the national programs may not have that kind of a skill set in engaging in managing the private providers, because private sector functions on the principle of profitability. and how do we really address that? I think these are like a couple of challenges. But to answer your question, most of the states have come forward, and most of the states have proposed in their annual plans, and NTEP has sanctioned those partnerships under their annual plans. The critical challenge is somehow we are overcoming that by establishing national technical support unit at the national level, as well as 9 priority states. But those are not limited to 9. It can be spread across all major states. So these technical support units will bring in those skill sets which probably not available in NTEP, in terms of formulating the partnership between these private sector or implementing agencies who will act as a mediator between private providers as well as NTEP. I think these are like so far what we have seen as more encouraging results, like states like Bihar, Jharkhand, Madhya Pradesh, Andhra Pradesh, and many more states have already entered into our partnerships, and they are seeing a good number of notification. But at the same time, it is not just a notification. What we are looking is entire care cascade of services until they report successful treatment outcome. It has a great potential. Unfortunately, yes, COVID has really disturbed the entire ecosystem. But I think not only engaging the private providers, but I think it has a greater scope in terms of engaging the diagnostics, which definitely help in terms of early diagnosis and initiation of early treatment. Yeah.
So thank you, Dr. Venkatesh. If there are no further questions, we really appreciate your time and delivering an excellent talk today. Thank you.
Thank you.
With that, I invite our next speaker, Dr. Kiran Kumar Rade. To introduce, Dr. Rade is National Professional Officer at World Health Organization India Office. He is a public health professional and epidemiologist with keen interest in control of communicable diseases, especially tuberculosis, malaria, and leprosy. At WHO Country Office, Dr. Rade is engaged in providing technical assistance to India's National TB Elimination Program in diverse and challenging conditions. To his credit, he was responsible to provide leadership in implementation of National Tuberculosis Prevalence Survey to estimate TB burden and mortality prevention. The case-based, web-based real-time TB surveillance system of Government of India called NICSHE is Dr. Kiran Rade's brainchild. Dr. Rade has also been instrumental to roll out direct benefit transfer for TB patients, which is the flagship government scheme to provide nutritional support to TB patients at the time of TB notification and subsequently during the course of their treatment. With this background, I invite Dr. Rade to talk on challenges, solutions, and initiatives in tuberculosis research and epidemiology, India perspectives. So over to you, Dr. Kiran.
Thank you, Dr. Shikha. Is my screen visible?
Yes.
Okay, thank you for inviting and giving me this opportunity. I'll be quickly covering about the challenges and solutions and the some of the initiatives in TB research and epidemiology with a focus on India. And especially the 2 initiatives of subnational estimations and e-rupee as an example, though there are many initiatives happening in the country. To give a perspective, one of the major challenges that we are facing is the research questions. Many youngsters, research institutions are usually aware about what are the challenges in the program, but the questions are also too many and diverse. So one of the challenges that is faced by a young researcher is which question to identify and address as a research question. And in this regard, the program, the TB elimination program, has come up with the prioritization list, which is updated regularly, and you can find it on the TBC India website. And that is a I can say, a proper solution which is helpful for the researchers to prioritize as to amongst that list which one they can take up for the research purpose. Second thing is funding. Of course, Indian public health system has gone through different phases, and once upon a time there was not adequate funding for research, especially for tuberculosis. But now there are enough mechanisms, including the national research mechanism within the program at different levels. Also, India TB Research Consortium under ICMR. So there are different mechanisms which have been evolved over a period of time, and the budget earmarking by both the program as well as the research institutes for tuberculosis as a priority has been helpful. And the third challenge that we see in the ecosystem is overlap of the mandates. Operational research may be the priority of the program. Basic research as well as validations of the newer technologies will be the priority of Indian Council of Medical Research, and fundamental research, product development will be the research priority for DBT and bioreactor mechanisms, but there will always be overlap. So naturally the solution is coordination. Most of the experts in these committees who review the proposals are, you can see them interchangeably, and the coordination between them is the probable solution. Now coming to the TB specific, particularly related to the nitty-gritties of the research areas, one big challenge that almost for everything in the country we see is diversity. Diversity in terms of the determinants of TB, call it HIV or malnutrition, the predictors of tuberculosis. When they are diverse, what happens is when the researcher is doing any particular study in a given geography, the results may not be extrapolable to the rest of the country or the other geographies because of that diversity. And one solution is managing the or institutionalizing the studies with multicentric approach, wherein you capture the diversity. Second is within the geography or for a given area of research, if you stratify the sample and your design is such that it takes care of the diversity to address or identify and answer the research question, then things are taken care of. In the absence of that, the extrapolability of the research findings is usually an issue. The second big challenge, not only in India but globally, is burden estimation. Estimation of tuberculosis incidence or prevalence or mortality for that matter is not that easy in the absence of a very good surveillance system with good coverage. And many a times we struggle even at the national level estimation with a wide confidence interval in the absence of data. But the subnational estimation is actually more important and was lacking for all these years together. And one single figure for the country, we cannot expect the rates of tuberculosis similar in all the states or within the states and different districts. And this is one challenge, and attempt for this estimation is the solution, and that has been tried and discussed that quickly. Then in the cascade of care, the leaks right from the onset of disease till the diagnosis, then the treatment initiation, treatment completion. In this whole care of cascade, there are leaks. And some of these leaks cannot be actually routinely quantified or investigated in a routine inquiry. For example, if we know how many number of patients have been diagnosed, of course we can find out how many are put on treatment. That is a simpler one. But there are missed opportunities like the onion pill model. There are health facilities wherein even the presumptive TB will be missed, and they may not be offered on a particular occasion the diagnostic test. Then how do we actually quantify this? We cannot do it in the routine manner, and we have to be innovative. We have to use standardized patients. We have to use exit interviews, facility or community-based approaches like the QPS finding. to identify this cascade of care. Another big one is vaccine. People usually compare in the COVID era that within 1 year COVID came as a pandemic, but we had the vaccine, not one but multiple. But for TB, though it is the highest burden in the world, India's burden, still we are left with a single vaccine which is 100 years old. One of the reasons is the lower odds of success. That's what usually the pharmaceutical industry or the vaccine development manufacturers would look at it into, and that's where comes the advocacy. And we really have to look into how and who are the potential investors and how the government can give the stake into the research and development so that there are enough efforts for development of TB vaccines also. Then comes another big challenge is the multiple sites of the disease. It's not just the pulmonary but extrapulmonary, and the sample collection is a big challenge. Similarly, in the pediatric age group and the population, collecting that clinical sample is challenging and can be we need to have multiple strategies and research methods to demonstrate that in the public health program, how do we establish such a difficult clinical sample collection? And another big issue we can say is the natural history of the disease is still not fully known. For example, the endpoints, whatever intervention you decide or study you're doing on TB patients, the endpoints are not clearly defined, like many other diseases wherein the antibody levels, titers, or many other biomarkers are very well established. But for tuberculosis, there are not very specific biomarkers, though the recent research, especially in South African countries, have come up with some of the biomarkers which are promising, but not yet fully established. But these biomarkers research is the solution for understanding this natural history of disease, which can be used for defining the endpoints for that will be helpful for any clinical research for TB. Then the larger one, big animal, very easy said and but difficult to be done is the health system approach. TB programs as a vertical approach will not be sustainable for a long time. And universal health coverage and NHM as an umbrella approach is the solution for sustainability purpose. So these were some of the challenges and solutions. We'll discuss it later. But one or two examples I want to quote. One of them is the burden estimation, and that to subnational estimation of burden. The program last year actually ventured into promoting the healthy competition between the different districts in the states in the country and incentivizing them for their efforts towards ending TB in the form of giving the bronze, silver, gold, and awards and TB-free status awards if they achieve 20%, 40%, 60 or 80%, which is the SDG target reduction in the incidence to promote. But it was not that easy, and they had to really establish this methodology because no one has done it before. So that I would like to express. This was the process that was followed. All the states and districts were encouraged to apply for this, and there were prerequisites set up that there should be at least 20% or more applying in the drug cell of that particular district as compared to 2015. There should be minimum 20% increase in the number needed to test because it is reciprocal with the case as a case finding effort. And if you have the increasing NNT, then there is a good chance that for identifying one TB case, you have to do more and more efforts. The third prerequisite for allowing that district was a TB score. TB score is a composite score taking into account the performance of the program in that particular district, and it has to be more than 80 out of 100, so that we can assume that yes, the program is functioning well and is having the impact. And then the verification of the claim was done by National Institute of Epidemiology of Indian Council of Medical Research, was supported by WHO India and Indian Association of Preventive and Social Medicine for verification of this claim. And there were three major components, four major components, I can rather say. The district level surveys based incidence estimation, both using the direct and indirect method. The verification of the drug cell data, because we all know at least 50% patients in majority of the districts do seek care from the private sector. And the verification of the TB score, not just by as claimed by the district, but verified by the third party or agency, and also the information on the number needed to test. So these were the four major components, and there was a system established to conduct these surveys across these districts which had applied for this particular claim. The drug cell data, of course, whatever is the number of rifampicin tablets or the strips that were sold in the given area or consumed in the public sector as well as in the private sector, and methodology which is proven, and there are a couple of papers also which have been shown to be useful in understanding that how we can use the drug cell information for establishing the number of estimated patients in a given year. The second was under notification. Based on the survey, we have the notification rate, and during the district survey, we identify what proportion of the TB patients found in the community are outside the existing surveillance system of NICSHE, and adjusting for that under notification can estimate the TB incidence. So this was the second method. And the third method for using estimating the TB incidence was the direct measurement, the actual number of episodes in the community, counting them based on the cutoff date of the date of diagnosis in last 1 year, analyzing and adjusting out for the transfer in, transfer out, source of treatment and basis of diagnosis, and finally counting the capita of the total incident cases in the given year. And this has been helpful because in the absence of realistic estimations of TB incidence in a given area, it's difficult to manage the progress in the given program unit. These were the results, and actually two districts, one UT and one district in JNK, were found to have 80% reduction as compared to 2015. And this particular initiative is being transitioned and being established across the country. So this is one example as to if we scientifically develop a methodology and adopt it, implement it, we can really set out the surveillance system which is crucial for the country. So there are many strengths and challenges. I will not go into deep into it, but of course it's not a perfect method yet, and it can be further improvised. And another one potential thing I would like to put it to the house is the e-rupee. Many of you must be aware about the launch of this new mechanism, which was actually launched by the Honorable Prime Minister for COVID vaccination in the private sector. Those private sector entities, agencies who want to vaccinate their workers or the employees, for them this particular scheme was introduced, in which the vouchers are generated for use by their employees and given to their employees through this mechanism of e-rupee, and they can go to any place and get this vaccine done without paying, and just showing the electronic voucher that they have received on their mobile as a QR code or a SMS. it's a very, very convenient mechanism in which, without making any much of the efforts, we can ensure that the whatever benefit is defined can be given to the target population. So these are 5 of the areas which have been identified and has huge potential for the TB program to be implemented using the e-RUPI mechanism. One is the chest X-ray diagnosis. As our previous speaker has said, private sector engagement is ongoing, but to further facilitate it, if the vouchers can be created for chest X-rays, the liquid culture, which is very important for the follow-up of TB patients during treatment and post-treatment follow-up at 6, 12, 18, 24 months, then we can actually capitalize on the private sector strength of the number of digital chest X-ray machines and the capacity of the liquid culture to support the patients seek those services from the private sector at convenience. Then also there is a potential benefit to the program in terms of other things which can be envisioned. We can have the corporate sector scheme wherein the corporate sector can pay for their employees for a complete thorough checkup of their employees for tuberculosis, both latent TB as well as active TB. And this is the mechanism how it works. Though it looks complicated, this particular thing can be very well researched in the field conditions and can be augmented as a you can say game-changing solution for ensuring access to care in the country when it comes to tuberculosis. So these were some of the thoughts from my side. I would like to stop here. Back to you, Dr. Shikha.
Thank you, Dr. Kiran, for giving us an overview of research opportunities that can be taken under programmatic settings. So now I invite audience if there are any questions from the physical participants or the virtual participants. So, Dr. Kiran, I have a question myself. When you talk about awarding states for going towards TB-free plan, so can you please let us know when is the next survey or when is the next round planned for it?
So the next round will start in January, and the aim is that every World TB Day, the districts which are going ahead well on these milestones are encouraged and incentivized on the World TB Day. So it would start in January.
Okay, that's excellent. And can you also comment on, in general, about how these schemes are taken up by the citizens? Because I'm not talking under the program perspectives and the stakeholders. Do we know how much the general population is also going to benefit from these schemes?
Yes, actually it is intended for general population over a period of time, especially when it comes to TB preventive treatment. Then some of the tests, if e-RUPI can be used for this, general population can avail them. That's the whole intent over a period of time.
So, thank you, Dr. Kiran. Now,
I have one question.
Request. Okay, Dr. Pavan has a question for you, Dr.
Dr. Kiran, it's very nice that WHO is making a lot of commitments and a lot of efforts. But one thing which I feel we are still lagging far behind in extrapulmonary TB diagnostics, as well as because it takes long time actually to really diagnose it, in fact if it is an extrapulmonary TB. That's why the treatment takes then starts late and the effects are. So anything being actually done in this direction?
Yes, sir. Actually, the global recommendations are there for extrapulmonary and also specifically in the child age group for other clinical specimens, including the stool. As far as India is concerned, index TB guidelines were developed mainly by AIMS New Delhi and WHO India, which takes care of this, but having guidelines alone is not sufficient. I agree with you. The big challenge is the specimen collection, and that too in the periphery. Apex institutes and tertiary care institutes they have all the facilities to collect the sample and process it, and even the experts which are needed for extrapulmonary diagnosis, that is not available across the country everywhere. And that is the challenge as to how do you link with the periphery, especially the secondary and the primary care level. And the telemedicine is one possibility which we are exploring, and it is turning out to be very helpful for diagnosis of extrapulmonary cases, wherein our basic medical officer in the periphery, in the PSC, is able to link, but that is on small scale as of now, and that should be the solution in long term.
I think that has to be little pushed up because I am
Yeah.
seeing lots of gaps and diagnosis in this direction nowadays. Because many patients I have seen it took almost 1 to 2 months, in fact, to know first of all there is a TB and then extrapulmonary TB. So
Very true, sir. That is our finding also. I mean, when we talk about out-of-pocket expenditure, which is one of the impact indicators, the catastrophic expenditure, especially extrapulmonary cases, it takes a huge amount of money and diagnostics outside the public system, for which the patient has to pay out of pocket in addition to the morbidity which he suffers from. So that is an important area. I agree with you.
thanks a lot. It's a really nice talk. And Shikha, the mic is with you now.
Yes, sir. So if there are no further questions, we would thank Dr. Kiran for his time and giving an excellent overview of research with Indian perspectives under the program. So Dr. Asif, over to you to conclude the session.
Okay. Thank you, Shikha, for coordinating the session, and I thank all the speakers for such wonderful talks. It was a very nice session. And now we'll close the session and we'll join at 2:30 from the second Zoom link. And our first speaker is Professor Shekhar Mande, Director CSIR. So please join at 2:30. Okay, thank you everybody.
Thank you.
Thank you.